Welcome to this explainer on Clinical Case Files Urology and Nephro-Oncology Board Review. Today, we are going to zero in on pattern recognition and those absolute high-yield pearls you need to know.
We've got a great lineup today, moving through 5 key clinical areas, starting with renal cell carcinoma, then pediatric urology, pelvic oncology, trauma, and finishing up with transplant complications.
Okay, let's jump straight into Ward 1, focusing on renal cell carcinoma and navigating oncology diagnostics.
Picture this. You've got a 49-year-old guy with confirmed clear cell RCC. He comes in complaining of this relentless, new-onset lower back pain, and his serum ALP is significantly elevated. But here's the catch. His standard technetium 99am bone scan comes back completely equivocal. It's just not giving us a definitive answer. So what's our most appropriate next step?
Think about the imaging modality you'd order right now. Are we looking at a CT scan of the spine, a spinal MRI, a repeat bone scan, plain X-rays, or maybe a PET scan?
Well, if you went with B, a spinal MRI, you hit the nail on the head. Here is the critical exam pearl. RCC skeletal metastases are notoriously osteolytic. Basically, they destroy bone without triggering the reactive osteoblastic remodeling that a standard nuclear scan needs to actually show a hotspot. Because they're purely lytic, they easily give false negative results on a standard scan. A high-resolution spinal MRI is definitely the way to go because it gives you superior sensitivity for catching early malignant marrow infiltration before the bone structure even changes.
Right, let's move right along into Ward 2, congenital and pediatric urology, where we're differentiating abdominal masses and anomalies. Here is our next case. An 18-month-old child presents with a large palpable abdominal mass. In this specific age group, we need to rapidly differentiate between the two most common pediatric abdominal malignancies, a neuroblastoma and a Wilms tumor. Imaging is obviously part of the workup, sure, but consider which of these specific laboratory parameters provides the definitive biological fingerprint here. The definitive marker is A, urinary catecholamines. Let's break this down real quick. Neuroblastomas come from neural crest cells, so they secrete high levels of catecholamines, like VMA and HVA. They usually hit kids under 3. The mass itself often crosses the midline, and the child usually looks pretty chronically ill. On the flip side, Wilms tumors typically show up a bit later, around age 3 to 5. The mass is smooth, it stays lateralized, and crucially, it does not secrete those catecholamines.
Now, take a look at this beautiful radiographic finding. This is the classic pathognomonic cobra head sign on an IVU. That halo right there indicates a ureter seal, which is a cystic dilation of the terminal ureter bulging straight into the bladder. The really high-yield takeaway here? Ureter seals are highly associated with a duplicated collecting system, and they routinely drain the upper pole of that duplex kidney. That's known as the Meyer-Weigert law.
Moving right along to Ward 3, pelvis and bladder oncology, looking at surgical pathways for urothelial carcinomas. Imagine a patient diagnosed with a large unilateral transitional cell carcinoma, or TCC, sitting right there in the renal pelvis. Remember, this cancer targets the continuous epithelial lining of the urinary tract.
So, what is the absolutely safest, most definitive management option here? Systemic chemo? Local radiotherapy? A radical nephrourectomy with a bladder cuff? A simple total nephrectomy? Or maybe just active surveillance? It's C, the radical nephroureterectomy. You've got to take the kidney, the entire ureter, and a cuff of the bladder wall. Why? It's because of this fascinating but dangerous phenomenon called field cancerization. The entire urothelium has been exposed to the exact same carcinogens. If you just do a simple nephrectomy and leave the ureter behind, you're looking at a staggering 50 to 60% risk of recurrence right there in the remnant. We just can't risk it.
Okay, Ward 4, let's step into the high-stakes world of urological trauma and infections to review emergency protocols. This matrix right here is a literal lifesaver for dictating upper tract decompression. If your patient has a simple stone and they're stable, a retrograde stent is perfect for internal decompression. But if they're septic with pyonephrosis, meaning that kidney is full of thick pus, a stent will just clog up immediately. You need to place a percutaneous nephrostomy, or PCN, for high-volume external drainage. And if they only have a solitary functioning kidney, that's an immediate emergency requiring urgent intervention.
Let's put this into practice. A 44-year-old male takes a high-velocity blunt impact to the flank,
but he is completely hemodynamically stable. His CT shows an AAST grade 2 renal injury with a localized, non-expanding paranephric hematoma. What's the optimal management for him? Needle aspiration, conservative observation, rushing to the OR for an emergency laparotomy, total nephrectomy, or transcatheter stenting?
The right call here is B, conservative observation. This is a super reassuring pearl to keep in mind. Over 90% of blunt renal injuries are managed non-operatively as long as the patient remains stable. If their vitals are rock solid, bed rest and monitoring are your best tools. You're really only rushing to the OR if they're in uncorrectable shock, the hematoma is rapidly expanding, or if the renal pedicle is completely avulsed.
Finally, let's wrap things up in Ward 5, renal transplant complications, for some critical post-op troubleshooting. You get paged about a 55-year-old post-op patient. They've got an indwelling Foley catheter, but their urine output just plummeted to 15 millimeters per hour. For a typical patient, that is well below the oliguria threshold. The graft is struggling.
What is the literal first thing you do? Inspect the tubing and flush it, give an oral thiazide diuretic, hit them with an IV furosemide bolus, push an IV normal saline bolus, or just continue surveillance?
You've got to go with A. Step 1 is always rule out a simple mechanical obstruction. Check the tubing for kinks and flush the catheter with sterile saline to clear out any blood clots or mucus plugs. You only move on to checking fluid status or ordering a Doppler ultrasound for vascular issues after you've confirmed the plumbing is totally clear. Never jump to heavy diuretics before checking the tube.
So, armed with these high-yield diagnostic patterns, what subtle clinical clues are you going to catch on your very next shift? Keep connecting those clinical presentations right back to the underlying pathology, and you'll be golden.